Okay, hello everyone. This is Hella. I think you know me by this time. It's hard to kind of keep you awake after Akshay's wonderful lecture. I'm going to talk about hypoventilation and respiratory muscle diseases. I would like to remind you that 10% of your pulmonary boards are going to be sleep. Okay. So basically, the respiratory system is comprised of lungs and the rib cage and a pump, chest wall, muscles, all of that. So usually disorders of the lungs would cause you to be hypoxic. Disorders of the pump usually tend to cause hypercapnia or elevated CO2. So what type of disorders are we looking into? You have respiratory muscle disorders that would include Guillain-Barré, ALS, Myasthenia Gravis, and multiple sclerosis. Chest wall disorders include kyphoscoliosis, pectus excavatum, and obesity. We're not going to address those today. We're going to focus more on respiratory muscle disorders. So a little bit of calculations here. So carbon dioxide. Carbon dioxide in the blood, PaCO2, is usually related to the amount of production of CO2, which is VCO2 here, and alveolar ventilation. So it's proportionate directly proportionate to the amount of production and the alveolar ventilation. If we revamp this calculation, and please don't pass away, I'm just gonna basically focus on the important things here. What you need to kind of pay attention to is that CO2 is related to minute ventilation and is proportionate to the dead space ventilation. Keep those two concepts in mind. So what happens, what can cause CO2 to be elevated in the blood? Overproduction of CO2, which is usually not really a big issue unless you have problems with ventilation, and decreased alveolar ventilation. Again, calculation. So what can cause your minute ventilation to decline here? Decreased respiratory rate, decreased tidal volume, elevated dead space. So usually when your minute ventilation decreases, when your tidal volume decreases, you're going to try and compensate by increasing your respiratory rate. However, increasing your respiratory rate is going to cause rapid shallow breathing and would eventually increase dead space ventilation. So whenever you have hypercapnia and alveolar hypoventilation, neuromuscular diseases, the main causes the main things that are causing that is decreased minute ventilation and elevated dead space ventilation. Okay, enough calculations. So alveolar ventilation, we're all familiar with what can cause the reduction in ventilation. Starts with the CNS, won't breathe, and then can't breathe. That would include peripheral nervous system, respiratory muscles, and chest wall, upper airway problems. Can't breathe enough whenever you have problems in the lung like COPD, hyperinflation, emphysema. So what are the respiratory muscles? So if you take a look at what are those, the main principal one, here you're going to find the inspiratory muscles. Here you're going to find the expiratory muscles. The diaphragm is the main principal inspiratory muscle. You're going to have the external intercostals, the intercondylar parts of the internal intercostals, and your accessory muscles of inspiration are going to be the sternocleidomastoids and the scalenes. Muscles of expiration, whenever you're quietly breathing, you really don't need to use a lot of muscles. Your diaphragm is kind of like elastic recoil of the diaphragm and the rib cage. However, when you're actively breathing and trying to blow out the air that you breathe, then you're going to activate your abdominal muscles, rectus abdominis and obliques, as well as your internal intercostal muscles. So the diaphragm, in inspiration, usually contraction pushes down abdominal viscera, displaces the chest wall outward. Rib cage kind of comes up upward and outward, inflates the lung towards its total capacity. And the intercostal and accessory muscles, they mainly stabilize your chest wall. Whenever you blow out the air, the diaphragm and other inspiratory muscles relax, allowing passive recoil and of the lungs and the rib cage. Your inspiratory muscles are the external intercostals. They are primarily inspiratory, responsible for increasing the anterior posterior diameter of the thorax. And usually you can observe the action of the intercostals in the upper few intercostal spaces while quietly breathing. The lower intercostals, they become active with increased ventilation. Scalene, sternocleidomastoids, trapezoids are recruited at high levels of inspiratory activity and are considered accessory muscles. Expiratory muscles. Thoracic expiratory muscles, they include the internal intercostals, abdominal respiratory muscles, rectus abdominis, transverse abdominis, external and internal obliques. They augment the passive recall of the lung, especially during deep and forceful breathing. As we said, like quietly breathing, you're just going to have passive recall of the diaphragm and the rib cage. This improves the diaphragm's mechanical advantage in the upright posture, especially during exercise. If you're trying to blow out, like you're going to use those muscles. So what are those? We've all done PFTs and respiratory muscles PFTs. So we're just going to talk about the types of pulmonary function tests that we get whenever we're trying to evaluate somebody with neuromuscular disease to see if they have weakness of their respiratory muscles. So we're going to start by static volumes. The most frequent abnormality whenever you're getting lung volumes, the one that you look at, it's vital capacity. And the most frequent abnormality is a reduction in vital capacity, pretty much. This kind of like portrays weakness of both the inspiratory muscles and expiratory muscles. Like inspiratory, you cannot inflate properly, and expiratory, you cannot blow out your air fully. In addition to direct effects of loss of muscle forces, reduction in compliance of both lungs and chest wall can contribute to reduction in vital capacity whenever you have chronic respiratory muscle weakness. The vital capacity shows a marked fall in the supine position in comparison to the erect posture because of the action of gravitational forces on the abdominal contents whenever you have bilateral diaphragmatic weakness, and keep that in mind. Usually in normal human beings, vital capacity in the supine position is 5 to 10% less than upright. Whenever you have a 30% fall or more, it's usually associated with severe diaphragmatic weakness. Usually when you're looking at volumes, residual volume is usually normal or increased, and particularly if you have expiratory muscle weakness, you cannot blow whatever air you breathed in. But if you're doing pulmonary function tests, you're doing lung volumes on somebody with neuromuscular weakness or respiratory muscle weakness, you're going to pay attention to what their vital capacity is. So advantages of measurements of vital capacity: excellent standardization, high reproducibility, were established reference values for ages, sexes, easily performed, widely available, it's everywhere, sensitive for assessing the progress in moderate to severe muscle weakness. Rate of decline has been shown to predict survival in ALS and Duchenne muscular dystrophy. Disadvantages: it has poor specificity for the diagnosis of respiratory muscle weakness, can be less sensitive with maximum pressures and mild weakness. Another test, we're going to talk about dynamic spirometry, FEV1, FVC, and all of that. Usually, whenever you're getting dynamic spirometry, it's not as useful to you as like the specific tests of the muscle forces or like the vital capacity. You can see reduction in flow volume loops. It's effort dependent. They're easily performed. You're going to get PFTs on everybody that comes to the clinic. Intersubject variability is greater than vital capacity. And maybe like if you look at the flow volume loops, you can kind of like, hypothesize if you see certain patterns, like what could be the cause for respiratory muscle weakness. Like for example, a sawtooth pattern can be seen in like maybe in Parkinson's disease, muscle weakness related to that. But this is also non-specific, and you can see it with other people in obstructive sleep apnea and snoring. So you take it with a grain of salt. What about ABGs? So whenever you have mild weakness of respiratory muscles, CO2 is usually either less than normal. Mainly it's because people are kind of like breathing rapidly, so you're kind of like hyperventilating pretty much. Whenever your disease progresses and there's no pulmonary disease, daytime hypercapnia is unlikely. But if your respiratory muscles strength decreases to less than 40% of predicted and your vital capacity is less than 50% of predicted, you're going to start having rises in PCO2. Whenever you have somebody who's floridly hypercapnic, it usually implies late and severe impairment of the muscles. So sometimes it doesn't kind of like give you like super accurate information. If you have daytime values, it can underestimate the severity of gas exchange, especially if you have somebody who is hypoventilating when they're sleeping and they wake up in the morning and then they breathe normally and then like the CO2 normalizes. How about sleep studies? So basically, moderate severe respiratory muscle weakness, you're going to have oxygen desaturations whenever you're having REM sleep period, especially that you're going to run into muscle paralysis during REM sleep. At the beginning, usually whenever you have muscle weakness, your hypercapnia usually starts developing during sleep. Sometimes, like if you have somebody in a sleep lab and you're continuously monitoring CO2, you can see gradual rise during REM sleep. Early morning after waking up, like it's going to be more elevated than during the day. Patients are going to run sometimes into symptoms of nocturnal hypoventilation, frequent apneas, hypopneas, like whatever happens in terms of headaches, daytime sleepiness, lack of energy. Also, if you have like sleep disordered breathing that's not related to hypoventilation, you can have those problems as well in patients with neuromuscular weaknesses. So nocturnal hypoxemia is a less gut prognostic indicator than vital capacity or awake PA CO2. So you don't have to do CO2 during sleep. You can rely on awake CO2 and vital capacity. You do sleep studies, especially in patients with symptoms, daytime sleepiness, suspected nocturnal hypoventilation, especially their awake CO2 is borderline or elevated. The severity of nocturnal desaturation, you can predict that somebody is hypoventilating during sleep from their daytime measurements, especially if you have somebody who has like a CO2 that's higher on the higher side, they're desatting, they have lower vital capacity. So you really don't have to do a sleep study in order to deduce all this information. You should perform it in all patients where you're considering to put them on BiPAP to titrate it properly. You don't have to get it in every patient with muscle weakness in the absence of relevant hypoventilation symptoms. So now let's talk about tests of muscle strength. So those include PI max or maximal inspiratory pressure or PE max, maximal expiratory pressure. PI max SNIP reflects the strength of the diaphragm and inspiratory muscles. Usually, you measure that during the maneuver, and we're going to talk about it. At residual volume, you ask the patient to blow out everything that they have breathed in, and then you ask them to do a Mueller maneuver, which is like breathing, taking a deep breath against a closed glottis. They maintain that for about over 1.5 seconds. And then maximum negative pressures are three to 5 maneuvers, depending on the lab, that vary by less than 20%. You record the highest value. In terms of expiratory muscles, like it's going to be like pretty much the reverse. It reflects the strength of expiratory muscles, measure the total lung capacity, and then you attempt the Valsalva maneuver that's kind of like trying to breathe out against a closed glottis, maintain for 1.5 seconds. Same thing. Maximum positive pressure, here negative pressure, of 3 to 5 maneuvers that vary by less than 20% or 10 millimeters is recorded, and usually you have to sustain that for 1 hour. These tests are easily performed. However, they require patient cooperation. You have to coach them through this, and you have to tell them what to do, and you have to demonstrate that to them over and over. You have reference values that are adjusted according to age and sex and height. So like a couple of important information. If PI max is less than 1/3 of normal, it predicts hypercapnic respiratory failure. PE max less than 60 centimeters of water predicts a weak cough with difficulty in clearing secretions. SNIP or sniff nasal inspiratory pressure. It's an indicator for inspiratory muscle strength. It pretty much can like assess contraction of the diaphragm and other inspiratory muscles. When do you use this maneuver? This is useful in patients with ALS or other types of muscular weakness that have facial weakness who cannot obtain a tight seal around the mouthpiece for maximal inspiratory pressure maneuvers. Whenever you have nasal abnormalities, it's going to be less reliable, especially if you have occluded nostrils, nasal polyps. And I'm going to show you like the device that we do it with, and that will make some sense. Like, see, this is the device that you use for SNIP. It has a small plug that goes into the nose. So if you have like some sort of like occluded nerves or something that's not right in the nose, it cannot be as reliable. Patients hyperinflation and COPD, you're not going to able to have like a good transmission from the chest to the nose due to the abnormalities. So how do you perform the SNIP maneuver? Like a small plug is attached to a pressure transducer. You put it in one nostril, completely obstructing the flow. You ask the patient to inhale maximally through the one open nostril, and then they sniff as strongly as possible through the contralateral unobstructed nostril, and the peak negative pressure is recorded. You rest them for a minute and you repeat until a maximal peak pressure is obtained. It's easy to do than MIP, less coaching. You don't have to demonstrate the maneuver to the patient over and over again. And as we mentioned, those are the devices. Those are for the MIP and MEP, and they put in their mouth, they form a tight seal, and then they do the maneuver. This is when you have problems with your facial muscles. Okay, so management approach. So usually, pretty much majority of you're going to have different neuromuscular disorders, but pretty much everything from your pulmonary standpoint is going to boil down to three major things. So you're going to try and treat whatever underlying disease process, if it's ALS, MS, Myasthenia Gravis, Guillain-Barré, anything like that, you're going to have to try and diagnose it, treat the underlying disorder, or see what disease modification agents you can give. And then you're going to address hypoventilation. Especially if you're having nocturnal hypoventilation, you might want to start BiPAP. Awake hypoventilation symptoms include dyspnea, orthopnea, shallow breathing, and then you might then consider daytime BiPAP or even tracheostomy, tracheostomy and mechanical ventilation. You're going to have ineffective cough due to the bulbar muscle weakness and the rest of the expiratory, inspiratory muscle weaknesses. That will cause you to have retention of secretions, recurrent pneumonias, recurrent aspiration pneumonias. And whenever you're having bulbar muscle dysfunction, you're going to run into drooling, dysarthria, inability to clear secretions, and aspiration. Okay, so we're going to talk about how to treat the three major things that we need to address, and then we're going to go into some questions and try to kind of learn a little bit about each disease process. So BiPAP or non-invasive positive pressure ventilation is usually the preferred method for patients with neuromuscular diseases. Improves their symptoms of fatigue, daytime sleepiness, morning headaches, as well as their gas exchange. There were studies that after they established the patients with non-invasive positive pressure ventilation, they withdrew the positive pressure ventilation, and then symptoms recurred, hypoventilation recurred, so they had to put the patients back on them again. You're gonna move to tracheostomy, especially if you have a patient with bulbar dysfunction, facial muscle weakness, which prevents the use of non-invasive masks, or whenever you're having somebody with uncontrolled aspiration, then your BiPAP mask is not gonna be safe. For example, majority of the studies were done on ALS, and this is where we can get our information from. Many non-randomized trials suggested improved survival with the use of non-invasive ventilation. There was a study of ALS, 22 patients were randomized to receive non-invasive positive pressure ventilation. Those survived 205 days longer than the 19 patients who did not receive non-invasive positive pressure ventilation with the same medical care. Based on those several studies, the expert panels nowadays are recommending the use of non-invasive positive pressure ventilation whenever we're going to talk about the criteria whenever you're running into that in patients with ALS. Other neuromuscular diseases, there are less data available. It's tough to kind of sometimes conduct a randomized controlled trial because they're going to run into hypercapnia and hypercapnic respiratory failure, and what's the end that's going to happen with that. So if they can deduce from those studies that were done on the ALS patient, that would be useful for the rest of neuromuscular weaknesses. In terms of cough insufficiency, whenever there's inability to expectorate secretions, whenever you have somebody with a really shallow cough and you have recurrent respiratory infections, usually the way you assess the cough is measuring peak cough flow rate, which can be measured like an asthma peak flow meter, or there's an office spirometer like that one here that's connected to a face mask or mouthpiece, and then you ask the patient to cough and you can get the values on the screen. So the normal values would that range from 360 to 960 liters per minute. Any value below 160 liters per minute puts the individuals at high risk for cough insufficiency and ventilator dependence. There are cough assist devices, like something called a mechanical insufflator or exsufflator. It assists cough by delivering through a face mask or mouthpiece a brief positive inspiratory pressure to the airway followed by negative pressure, resulting in expiratory cough flows that would be substantial enough to clear the airway secretion. So this is what you're going to see when you go to the hypoventilation clinic, when you see the patients over there. Literature supports the use of these devices in neuromuscular diseases. There's also vibratory or oscillatory devices like the vest and all that. They shake the secretion, but they do not remove them from inside your airways. However, everything like the cough assist devices and all of the vests and every oscillatory methods, they would help decrease hospitalization, antibiotic use in patients with muscle diseases. Now, swallowing dysfunction, it's very common, especially if you have patients with bulbar muscle dysfunction. Weakness of lips, tongues, pharyngeal and laryngeal muscle can increase the risk of aspiration, and then you cannot generate adequate glottic closure for cough to kind of clear those aspirated secretions. The most important thing is that it poses a nutrition challenge because choking can be common. If somebody's losing weight unexpectedly, then you're going to have to kind of put in your mind that you're running into muscular weakness. So what you can consider doing a swallow study. Treatments for that are going to be placing a PEG tube if the patient is having significant dysphagia and aspiration in order to deliver safe nutrition. Tracheostomy might be an option, diversion of the airway, but apart from that, there's nothing that you can do whenever that develops. Okay, are you guys still awake? So basically the lesion sites, whenever you're running into that, you can split them into brain, like you're having multiple sclerosis, strokes, like Locked-in syndrome, spinal cord lesion, like multiple sclerosis, motor nerve lesions, like ALS, Guillain-Barré, critical illness, neuromyopathy. When you have neuromuscular joint, neuromuscular junction problems like Myasthenia Gravis, Lambert-Eaton, and muscle fiber problems like myotonic dystrophy, dermatomyositis, polymyositis. In terms of symptom timing, you're going to have acute, chronic, and then relapsing or progressive symptoms. Acute, like acute myasthenia gravis crisis, Guillain-Barré, and you'll see those in the ICU. Chronic, like MS, ALS, myasthenia gravis, you'll see those in your hypoventilation clinic. Relapsing progressive symptoms like MS, like you're going to have relapsing remitting disease. ALS, it's kind of like progressively worsening until the end in myasthenia gravis with crises and whatnot. So the first case, a 62-year-old man with a history of hypertension and asthma is complaining of a chronic non-productive cough, recurrent bouts of pneumonia over the past year. None of these pneumonias were severe enough to require hospitalization, but he reports complete recovery after each period. Denied other symptoms, his wife has noticed that his dress clothes seem to fit loosely. He refuses to monitor his weight. After the last pneumonia, his daughter noticed some slurred speech. A stroke evaluation in the ED and CT scanning and MRI was unremarkable. He denies fevers, indigestion, heartburn, skin rashes, allergies, swollen glands, or anything. No travel outside his home state of Virginia. Reports arm and leg cramps, which he attributes to laziness and deconditioning after COVID. He has a dog and a pet bird. He has given up hunting recently. On physical exam, vital signs are normal. Pulse ox 95% on room air, moderate cachexia, slightly lethargic speech, clear oropharynx, clear lung fields to auscultation, no skin lesions, and brisk deep tendon reflexes. No lymph nodes were palpable, and 3 separate chest x-rays from June, August, and October revealed mild atelectasis and infiltrates in different lobes with resolution of abnormalities and subsequent chest x-rays. No mediastinal fullness, no lung masses on PA and lateral views. Attempts at spirometry did not yield reproducible results because he had difficulty keeping a good seal on the mouthpiece. Okay, which of the following regarding further evaluation is most likely to yield the correct diagnosis? Pursue serum and urine antigen testing for blasto, bronchoscopy with BAL. If he develops another pneumonia, perform complete blood counts, differential bronchoscopy for airway inspection, order IV contrast chest CT, including inhalation and exhalation images, arrange for EMG studies and referral for to neurology for possible underlying neurological disease. Who wants to take this? Rizal is looking at me. He's asking to answer that question. Okay. Any takers? Okay. Oh, well, look at that. It's actually 4. So this is pretty much kind of like classic presentation for ALS. ALS is a degenerative motor neuron disease that affects upper and lower motor neurons. Peak incidence usually occurs in 6 decades of life, men more than women. Respiratory and bulbar muscles are affected. Limb weakness is usually more present on presentation, 75% of the time we're going to have like more of a limb weakness presentation, but you could have like a respiratory muscle, bulbar muscle, kind of a picture in 25% of the cases. Pneumonia or respiratory failure are the leading causes of death. You're going to have sleep disordered breathing, and please refer them to Dr. Sharma here. With respiratory muscle weakness and diaphragm weakness in particular. And this increases in frequency as the disease progresses further and further. Okay. Non-invasive positive pressure ventilation is suggested for all your patients with forced vital capacity less than 50% of predicted. MEP that's less negative than minus 60%, meaning like minus 20, minus 10. Sniff nasal inspiratory pressure less than 40 centimeters of water. And whenever you're having a sleep evaluation that's showing desaturation at nighttime, or a sleep study showing sleep disorder breathing. Whenever you have worsening of their bulbar function, patients will end up needing tracheostomy and long-term invasive ventilation. 10% of the patients in the United States elect to go down that route. Usually, survival is 3 to 5 years after diagnosis. Tracheostomy can prolong life substantially, but does not affect progression of the underlying disease. Disease-modifying medications are going to be riluzole and daravone. Okay. Case 2. 60-year-old previously healthy man returned from vacation in Puerto Rico 7 days ago and now complains of 3 days of rapidly progressive arm and leg weakness and shortness of breath. While on vacation, he had a flu-like illness with fever, malaise, myalgia, and a diffuse rash, all of which improved over the next 3 days. On physical exam, heart rate was 100, BP 130 over 70, respiratory rate 28, O2 sat is 90% on room air. He has bilateral symmetrical weakness of the extremities and hyporeflexia with mild sensory deficits in the fingers and toes. The remainder of the exam is normal. Which of the following treatments is most likely to slow the progression of his limb weakness and dyspnea? Doxycycline, combination antiretrovirals, corticosteroids, IV immunoglobulin. Dr. Sharma wants to answer that question. Absolutely. See, he's already a sleep doctor. It's IV immunoglobulin. What do you guys think this guy has? Guillain-Barré. Naturally. So Guillain-Barré is an acute demyelinating polyneuropathy. It's usually triggered by infection, sometimes respiratory, and there are reports of COVID-19 causing Guillain-Barré. Progressive ascending flaccid paralysis, usually all myelinated nerves, motor, sensory, cranial, sympathetic, everything can be affected. In order to diagnose, and this is why I'm going to talk a little bit more about this, because actually you can have somebody like that in the ICU. And one of my patients earlier this year got admitted with Guillain-Barré. You're going to have progressive weakness of the arms and legs, minimal weakness to all four limbs, paralysis, including trunk, bulbar, facial muscles, and external ocular muscles. You're going to have areflexia, decreased deep tendon reflexes and weak limbs. Those are required features. Supportive features, there are like a lot of supportive features. Mainly, you're going to have symptom progressions quickly over days to 4 weeks, cranial nerve symptoms, autonomic dysfunction, CSF with elevated protein, normal to mildly elevated leukocyte count, electrodiagnostic abnormalities that are consistent. And usually IV, IG, and plasma exchange have been both of them have been shown to be equally effective in improving disease outcome by accelerating recovery, but they do not halt progression or alter the nerve damage. Okay. Respiratory compromise can be linked to many factors: upper airway compromise and weakness of pharyngeal, laryngeal muscles causing aspiration, inspiratory and expiratory muscle weakness. What do you usually need to do in the ICU for these patients? You're going to have to monitor their vital capacity. If it's less than 60% of predicted or below 20 mL per kg, you're going to start talking about initiating ventilation. MET less negative than -30, or maximum expiratory pressure less than 40. When you're having rapid disease progression, bilateral facial palsy, autonomic dysfunction, time from onset to admission less than 7 days, and inability to cough, stand, flex the arm or head. Those are very alarming features that your patient is headed towards respiratory failure and would require ventilation. Okay, case 3. 58-year-old woman, I might add true story, past medical history of myasthenia gravis on 2 liters at home, presented to the ED with abdominal pain, nausea, vomiting. Prior to this admission, she was diagnosed with diverticulitis, sigmoid stricture. However, she failed to improve conservatively. And then she ended up undergoing a sigmoid resection by surgery, extubated in the OR without events. After arrival to SICU, the patient becomes acutely altered and hypoxic, eventually got reintubated for hypoxic hypercapnic respiratory failure. She is your clinic patient, and the PFTs that you've gotten for her vital capacity was 1.47 liters. Her PI max was 52, CO2 was 50, and she was initiated on BiPAP or IVAPs. However, she has not been wearing it as outpatient. Okay. What is the cause of her hypercapnic respiratory failure? Prolonged effects of rocuronium, myasthenia gravis, IV albumin or metadrin, or opiates? Who wants to answer this question? Absolutely. So whenever you have a myasthenia patient going into surgery, there are several, any stressor, paralytics that you give, pretty much like any major infection will precipitate a myasthenia crisis. This woman was pretty much controlled. She's actually my clinic patient. She has gotten COVID-19 back in March of 2021, spent a month on the ventilator. She was really difficult to wean. After COVID-19 diagnosis, she went through like another myasthenia gravis crisis, got stabilized, extubated, persistently hypercapnic, persistently weak, hypoxic during the day. And we kind of like started working her up and kind of like initiated her on IVAPs, which she has not been wearing pretty much. Her PA pressure was like 60 on a right heart cath. And then she ended up going into this unfortunate situation, another MG crisis. Myasthenia gravis is antibody-mediated autoimmune disease. Acetylcholine receptors or receptor proteins in the post-synaptic membrane of the neuromuscular junction. It affects bulbar and ocular muscles more so than limbs. Repetitive use of muscles precipitate more weakness. You're going to have the dysphagia and aspiration because it's like mainly starts off in the head. It can also occur as a paraneoplastic syndrome, especially with thymoma. You'll have that question on the boards, I promise you. Approximately 15% of thymoma patients will exhibit myasthenia gravis. Removal of the thymoma may result in amelioration of the symptoms. Usually management, outpatient steroids, cholinergic agents, pyridostigmine, and immunosuppressants. And you're trying to kind of like prevent acute crises from happening. You're going to also have increased secretions from the cholinergic drugs, which make treatment of cough insufficiency a little bit difficult. On the other end, you're going to have Lambert-Eaton Syndrome, which is associated mainly with small cell lung cancer. It can affect the respiratory muscles in a fashion similar to Myasthenia Gravis. Affects the presynaptic neuromuscular junction, though. About 3% of cases of SCLC are going to have Lambert-Eaton. And usually you should keep on working up small cell up to 5 years after diagnosis of Lambert-Eaton. Respiratory involvement is usually more of a late finding, but it can be like the first manifestation. Actually, there was a case report about a patient whose first manifestation was florid respiratory failure due to Lambert-Eaton, and then eventually, after extensive workup, she was found to have like small cell lung cancer. The clinical presentation is going to be a little bit different than Myasthenia Gravis. An increase in the compound muscle action potential whenever you can like repetitively stimulate that nerve. You're going to have more common proximal leg weakness, worse in the morning rather than ocular and bulbar symptoms with Myasthenia Gravis. You're going to have greater autonomic dysfunction, areflexia, and again, it's associated with malignancy of the lung. One last honorable mention is diaphragmatic paralysis. It can be caused by both motor nerve and muscle weakness. Whenever you have a unilateral diaphragmatic paralysis, patients may be asymptomatic at rest, but they can have dyspnea with exertion. Orthopnea can be present, but it's usually more common if you have bilateral paralysis, because just look at the diaphragm goes up and all the abdominal contents press on the diaphragm. You're going to have an elevated diaphragm on the chest x-ray. If you have a unilateral paralysis, it's going to be easy. You're going to find the normal diaphragm and then an elevated diaphragm. But if you have bilateral paralysis, apart from seeing like the diaphragm at the lung apex, probably it's going to be a little bit difficult to kind of distinguish. You confirm with a sniff test. Pretty much what's going to show is an upward movement of the paralyzed hemidiaphragm whenever you're kind of vigorously sniffing. This paradoxical movement, it's just like the paralyzed hemidiaphragm, whenever there's increased intra-abdominal pressure, that's going to push up on the paralyzed diaphragm. This is what you're going to see on the sniff test. There's surgical plications if the symptoms are really prohibitive. And like if you have problems with vital capacity in FEV1, especially in the supine position, you have significant dyspnea. Whenever you have bilateral paralysis, there's usually a disease that's producing like a progressive muscle weakness. Most common causes are motor neuron diseases like ALS. Whenever you have bilateral paralysis, you're going to be more short of breath. You're going to have dyspnea with exertion. You're going to have sleep disorder breathing, hypoventilation. You're going to need non-invasive positive pressure ventilation. In PFTs, we're going to see decreased vital capacity. With a significant drop in vital capacity in the supine position of up to 50%. So if you have somebody in your pulmonary clinic and they're like, oh, you're looking at the chest x-ray, oh, there's paralysis in there, ask your respiratory therapist to perform a vital capacity maneuver whenever they lie down. It's not often reversible unless the disease is treatable. But if there's idiopathic disease process, there was a reported improvement of 50% in some of these individuals. It may take up to like a year and a half, 15 months from the onset of symptoms. Okay. To summarize everything, whenever you have a question on the boards, remember this diagram. Identify the respiratory symptoms of the neuromuscular disease. Is it going to be a bulbar problem? Is it a cough problem, or is it a ventilatory problem? Treat the underlying disease process if you can modify it as much as possible. Address hypoventilation with non-invasive positive pressure, tracheostomy and ventilation if needed. Address infective cough, use cough assist devices, and address bulbar dysfunction with certain medication that would decrease your secretions, or like PEG tube placement if the patient cannot eat reliably. Okay. Thank you, everybody.